We're sponsored by Baylor Scott and White Health, and we talk about things that are new to your health, good for your health, things about the health environment, lots of different topics. Today we're talking about joint replacements. And joining me is internal medicine specialist Dr. Sharice Wiley. Good morning, Sharice. And Dr. Jay Mabry, an orthopedic surgeon who is a joint replacement specialist. Good morning, Jay.
Morning.
Here's a question for you out there. Do your joints hurt? Lots of folks' joints hurt. Are you stiff in the morning? Are you wearing out your joints? Is exercise actually a problem? Here's a fact. Joint replacement surgery in this country have tripled in the last several years. Now, what is that about? Sharice, we like to exercise. We tell our patients to exercise. Are some of them doing that too much? Is that the problem with joint replacement surgery?
You know, I think that may be a growing trend that we are seeing, that we're seeing patients exercise actually too much. You know, for years I have, told my patients to exercise, and now in the day and age where people are running marathons and half marathons, and they come in with, knee pain, younger people than I would usually expect, not our, elderly population. And so I would ask, well, how much exercise are you doing, or how much are you running? And despite pain, the patients persist and they continue to try to press on to meet personal goals or whatever goals they have. So the short answer is yes, I think we may be, and that may be why we're seeing more joint replacements. I know Dr. Mabry will be able to speak a little bit about, his patient population, but I think the important thing is that we have to balance, our need for exercise and then listening to our body and not over exercising, doing those high impact things such as running.
Now, on the other hand, I remember years ago we would tell folks, okay, your joints are wearing out. You could benefit from a replacement. They only last a short period of time, so let's put it off as long as we can. So to you, Dr. Mabry, I suspect, though, the operations are better. The replacement devices are better, so the operation is improved. We don't have to wait until the last minute anymore. Is that a fair statement?
It is, and just to comment on Sharice's statement about over-exercising and high impact, she's right. The jumping up and down and impact is wearing out the joint, but that doesn't mean don't exercise.
Right.
Exercise in moderation, such as with cycling, the elliptical, or swimming, and avoid the half marathons. As far as the joint longevity, it used to be true that total knees and total hips would only last 5, 7, or at best 10 years. That was 30 years ago. Now with advancements in both metallurgy and plastic development, we're able to put in total joints today that can last 30 years or longer. The FDA has already approved one total hip that will last at least 30 years without wearing out. So we can afford to put these in younger patients. In fact, I did a total knee yesterday on a 52-year-old gentleman who was bone on bone, and he'll go back to riding his bike and swimming, but he won't go back to running his marathons.
I love that. We call it a poetic term, bone on bone, and I've heard that before. In fact, I've seen patients who have said, my x-ray shows bone on bone, I need a knee replacement. I asked them, does your knee hurt? No. You get around well? Yes. So I'm not sure that the x-ray actually predicts that you need for a replacement. Have you seen this, Sharice, where folks will say, look at my x-ray, I've been told that I've got to have something done, but I feel pretty good. What do you advise these type of folks, Dr. Wiley?
Well, just going along with what we said, we treat patients based on symptoms and not necessarily based on, lab reports and x-rays and imaging. They are helpful, of course, but, you tell patients at this point, you try to find out what they're doing in their life, and you want to preserve their functionality as long as you can. So you want to tell them, be careful, just what Dr. Mabry said, try to avoid some of the high-impact exercises, because there may come a time where you probably will start feeling pain pretty soon, and so you just want to, preserve what function you do have left in the joints.
And I'm sure, Dr. Mabry, you have criteria for which you predict that you'll need an operation or maybe won't need an operation. And what do you consider when a patient comes and says, I've got a bad knee or a bad hip, do I need a joint replacement? What criteria do you use, Dr. Mabry?
Well, I would agree with Sharice. One of the last things that I consider is the radiograph. The radiograph is just a picture, and as you've said, you have patients who are bone on bone, but unless that bone on bone arthritis is actually interfering with their activities of daily living and interfering with their lifestyle, then there really is no advantage to replacing that hip or knee. But if that arthritis is interfering with your ability to play the 18 holes of golf that you want to do every other day, then it may be beneficial. The criteria that I use are the effect on people's lives. Does it interfere with your ability to play with your grandchildren? Can you go up and down stairs? Do you have trouble doing your daily walk? Number two, have you exhausted all non-operative means of treatment? I'm surprised at the number of patients who come in who have not even tried Aleve. Of all things, Aleve, it's on TV, it really works. It's probably one of the most accurate commercials out there on drugs. It really does last all day, and people look at me like, oh my gosh, yes, why, I think that might help. And I tell them to come back if it doesn't work, and we'll see what happens. Then after that, if the Aleve doesn't work, we can use corticosteroid injections into the knee. We can also use canes or crutches, although I will say that the vast majority of my patients, especially women, will not use a cane even if it will relieve their symptoms because they don't want to look old.
Mm-hmm. You know, and modifying exercise, Dr. Wiley mentioned, also helps. So the anti-inflammatory medications, Aleve, Advil, ibuprofen, Motrin, those do wonders for a lot of folks indeed. And sometimes just changing the activity. Dr. Wiley, I know you believe in physical therapy, you believe in modifying exercise. Speak to that if you would.
Definitely. You know, that is something that we definitely believe in. And usually when my patients come in and they complain about joint pain, in particular knee or hip pain, you know, we kind of go through, I tell them sort of, you know, initially these are the treatments for your pain. You know, we can modify your activity. As Dr. Mabry said, you know, we want to try all of the conservative measures that we can. We want to do, you know, ice, elevation, NSAIDs. Some people can't tolerate NSAIDs, so I will even put people on extra strength Tylenol. And then physical therapy is very helpful. And then I tell them if that doesn't work, you know, and you have pain, you know, lasting more than 6 months, then we probably should visit, you know, our orthopedic surgeon for surgery consultation. So at that point, when they sort of hear the options, more than likely most patients want to do physical therapy to see if that would relieve some of their pain. Physical therapy has been shown to be very helpful because it strengthens the muscles around the joints, and so it helps patients actually with their mobility. So I truly believe in physical therapy.
You know, I've got to think also that you guys, Dr. Mabry, are so good at this operation now. It's so much easier than it used to be. That's got to be one reason we're doing more operations. Remember, in the past, it could take a week, sometimes 10 days to get over an operation. Sometimes these folks go home the same day or the next day after a total hip or total knee replacement. That's remarkable. How do you guys do that?
Well, in addition to the advances in metallurgy and plastics, we've also made some great advances in anesthetics. We have a new anesthetic out there called Exparel that we can inject around the joint, and it gives the patient pain relief for up to 3 days. In fact, Dr. Winter, you and I have a patient in the hospital now that I did a total knee on yesterday. We finished his surgery at 12 o'clock. He got to his room at 3 o'clock, and at 4 o'clock, physical therapy had him up, walking in the hallways. He did 30 feet, came back, went to bed. He may very well go home today, and he's 86 years old.
Wow.
I think physical therapy before surgery is a very good adjunct, and we do have scientific papers that show that prehabilitation works. Also, getting patients up on the day of surgery, making them mobile, and not really treating them like patients in the hospital, but more as a therapy client, makes them more positive about going home.
I have to admit, years ago, I did way too much work trying to prevent blood clots, pneumonia, deconditioning. That's less of a concern of mine now. The folks get up and around so much quicker because new techniques, the way you do this operation. That guy is pretty proud of himself. When I saw him yesterday afternoon, he said, I am going to go home tomorrow. I'm convinced that I'm going to be able to walk right out of this hospital through the front door. He was quite happy with that.
Yes, I think he's already tweeting that he was up and walking on the day of his surgery, not just 24 hours after surgery.
So, Sharice, what do you tell folks when they say, I think I need a new hip, a new knee? What's your criteria? When do you refer them to the orthopedic surgeon?
Sort of the same things that we've talked about. If it affects your life, if you're not able to do those things in your life that you usually would like to do, if we've tried all the conservative measures and we're failing, and you're still having pain, I usually try to give them a fair amount of time, sort of about 4 to 6 months is a sort of a good time frame to determine whether or not, joint pain will be relieved with NSAIDs or, intra-articular steroids. And so if you're having trouble getting up and down the stairs, you're having pain at rest, that's another, sort of concern when we say, well, you know what, it's probably time that we visit our orthopedic surgeon. And then one thing I really stress to my patients is their sort of, how aggressive are you going to be? I really stress to them that you're going to have to do rehab. Your part is going to really determine your outcome, and the way you rehab will decrease complications and so forth. So I really try to stress to my patients that they play a large part in their recovery from a joint replacement.
That's an important point. I've been instructed that the rehabilitation is important as the operation.
Exactly.
Dr. Randy, I know you're a big believer in post-surgical, I guess you call that rehabilitation. Before it's called pre-rehabilitation. What's that new word you threw out there a while ago?
Rehabilitation.
Yes. So I'm sure that's important afterwards, what the patient does. The therapist then is an important part of the team, I would assume.
Yes, very much so. We get them involved right away, and in fact they are up and looking for our patients on the day of surgery so that they can get to the room as soon as possible. The sooner the patient is up and walking, the better off they're going to be in terms of their lungs and also preventing blood clots.
Now, Dr. Wiley, here's a question for you, because I saw an ad the other day about getting a joint replacement cheap overseas. Do you ever have a patient, or let me ask you this, would you ever consider allowing one of your patients to go overseas to get a hip replacement done?
Well, that's a great question. Being an American, of course, we're going to be biased. However, studies have shown in past times that the quality of procedures are much better here in the United States. We have many regulations in place before, our training for most of our physicians here is pretty rigorous. And so I would actually not recommend that for my patient. I know some of the countries in Europe are, more as progressive as we are, and so that may be tempting for patients to, go to some of those countries as opposed to some of the third world countries. Of course, I would not recommend that. But, I guess the short answer is I would recommend that they stay here in the United States because of our regulations and because of the quality care that they would get and the quality training of our doctors here in the United States.
Yeah, the thought just makes me nervous about that. I don't like my patients to go across town to get an operation because I can't watch them as well as when they're in my own hospital.
Right.
So of course, the whole thing is cost. And so.
Right. And then when you get back to the United States, who's going to take care of you if you've gone, to another country to get a surgical procedure? Who's going to take care of you when you get back?
Yep. So cost is the question, Dr. Mabry. So when patients ask you that question, how do you answer that?
Well, that's a very good question, and it's a difficult one to answer because and I looked this up yesterday in anticipation of this interview, the cost for a total joint in Dallas varies anywhere from $28,000 all the way up to $160,000, and
Wow.
That's just in Dallas. And there are good studies out there in the orthopedic literature showing that there is absolutely no relationship between the cost of the operation and the quality of the operation. In fact, I would argue that those hospitals that have lower costs because they're more efficient, because they have tighter regulations, and they have a complete total joint program, as opposed to the smaller hospitals that may be charging more to make a quick buck. And I would echo everything that Dr. Wiley said about joint replacement overseas. You don't know what the quality is going to be like, and if you step off of the plane after your total hip from India and you have a blood clot, who are you going to see? Who's going to take care of you?
I hope you don't call me that. I hate blood clots. Those are horrible complications to have, but we do what we have to do, indeed. So let me get back to this one-day surgery. That really is fascinating, and you've done a couple of those on patients of mine, Dr. Mabry. They do spectacularly. How do you pick a patient? Who would you say would be the one that would be an ideal candidate for the same day or the next day going home operation?
Well, first of all, motivation is very important. Second, you have to have a very supportive family at home. You have to have the right type of home environment. Plus, if we can get patients to go to prehabilitation, and also we have a joint wellness class before every total joint surgery. So patients will come in and they will actually get to see the hospital and the therapist, the actual nurses that will be taking care of them. When you put all of those things together and you pick a patient who's reasonably healthy, then those are the patients that are the best candidate for going home. And I used to say that I would limit the 24-hour joint to my healthier, slimmer patients, but I have to say I've had a couple of total knee patients in the last month, each of whom weighed over 320 pounds, and I was surprised that even they did well enough. They wanted to go home the next day, they went home the next day, and they are doing fine.
Yeah. So knee and hip replacements are safer. They're have more predictably have better outcomes. They may even be less expensive sometimes. We want to prevent that when we can. Let's get back, Dr. Wiley, to this exercise thing. I'm a big believer in exercise. I know you are also. But our folks need to listen to their bodies. If your joints are active when you exercise, you may need to modify what you do in your exercise program. Speak to that if you would, Dr. Wiley.
Yes, you know, the hardest thing to do is to get a patient who is an avid runner to actually slow down, to listen to their body. But yes, modifying, doing lower impact exercises. I always, especially if patients have joint pain already, I'm a big advocate of doing water aerobics or some type of water exercise, because it actually, you know, buoyancy comes into play, and so it takes some of the pressure off the joints. So that's one option. And then also the elliptical. I do the elliptical myself. I do enjoy running, so this speaks to me as well, but I have listened to my body in the past, you know, and one other thing that I tell patients is to make sure that they're changing their shoes and they have good shoes. You should change your tennis shoes often when you are running. That's also an important aspect. You want to take care of your body if you are going to participate.
Dr. Mabry, any last comments from you about joint replacements? About
And you don't overdo things. Can you help me?
I think we're speaking over each other here. It's a little technical glitch there. Go ahead.
Oh,
Dr.
I'm sorry. Okay. No, I'm sorry. But I was just saying you want to make sense of your exercise. You don't want to exercise when your body is in pain. You want to limit what you do. The American Heart Association, I'll bring this point up, they recommend actually the simplest exercise. I tell my patients this all the time. 5 days a week, 30 minutes of walking. You can have the same effect for your heart. You may not burn as many calories, but you get the heart benefit, you get the exercise benefit, you even get the endorphin release benefit. So that makes you feel good. So I recommend that to my patients. You know, if all else, you can walk for 30 minutes and still get a good health benefit.
If your hips hurt, your knees hurt, less pounding, maybe more walking or swimming or elliptical training. Yeah, I agree with that. Final comments from you, Dr. Mabry. Give us kind of your overview of this topic.
Well, first of all, I would say total joint replacement should not be your first choice in joint pain. I would echo everything that Dr. Wiley said about treating this ahead of time with rehabilitation, water aerobics, modification of activities, anti-inflammatories before you consider joint replacement. That doesn't mean that you can't see the total joint surgeon, but really you need to consider all of the non-operative methods first. And then second, those people who have the most supportive environment and who are highly motivated will do the best with the 24-hour joint.
Well, thanks, Dr. Mabry. Thanks, Dr. Wiley. For you out there watching and listening, thanks for watching another edition of Healthy Hangout. We'll see you next time.
Thank you.